Okay, good afternoon, everyone. I'm really excited about this next panel, Medicaid Innovation in 2001 Beyond. As the resident Medicaid nerd at THP, this is my favorite one, and I'm very excited. And I'm especially excited to introduce you to our moderator, Matt Salo. His conference and our conference tends to overlap every year, and we ask him to come, and he often can't, so we were very excited to hear this year that we did not overlap, and we got Matt Salo to join us today. So if you don't know Matt, he's the executive director of the National Association of Medicaid Directors. That association represents all 56 of the nation's state and territorial Medicaid directors and provides them with a strong, unified voice in national discussions, as well as a focus for technical assistance and best practices. Before that, he spent 12 years at the National Governors Association, where he worked on the governor's healthcare and human services reform agendas, and spent the 5 years prior to that as a health policy analyst working for the state Medicaid directors as a part of the American Public Human Services Association. So without further ado, I'm going to hand it over to Matt.
All right, thank you so much, Lori, and good afternoon and to all of you. Thank you for having me here. It is always a pleasure to be in Austin. This is a town that's so great. My wife went to school here. We named our second child Austin, not after Austin Fract, although he's great as well, but this place always holds a near and dear space in my heart. So I don't know if everyone here is also a Medicaid nerd or just an aspiring Medicaid nerd. Hopefully, if you're not, then by the end of the hour, we can make you into one, because it really is a really obviously it's a very impactful program. I would argue it's the most important program we have in this country, but it's also really, really interesting and exciting and daunting. But it does such an enormous world of good for the health and the well-being of the citizens of this country, and of course the state of Texas, that I've been doing it my whole career, and I can't imagine doing anything else. But I am not the person you've come here to listen to learn from. We've got an incredible panel here, kind of the past, the present, not the future, but maybe the future Medicaid director of Texas is in the audience somewhere. There certainly are a bunch of other former Medicaid directors, but I'm going to introduce them real quick. I'm going to forego the lengthy bios. They're in your packets. And then what I'm going to do for this session is kind of tee up a couple of kind of broad themes that I see from my vantage point of working with Medicaid directors across the country, and have the three of them sort of talk about, is that true here in Texas? And if so, what does that look like? Or is Texas just different? And how does that work? So I'm going to do a alphabetical and longitudinal intro, starting with Billy Milwee, who was the Medicaid director in Texas from 2009 to 2012. He is an honorary gray beard of the association. We appreciate your work on our board. And he was the Texas Medicaid director when I first started the job, so you inherited me. I'm sorry about that. We will also have Stephanie Muth, who is the most recent former Medicaid director of Texas, and she was Medicaid director from 2017 to 2020. And last, and of course not least, the current and hopefully Medicaid director for a long time as well, Stephanie Stevens, who has been Medicaid director in Texas since 2020. Now, I was just kind of doing my back of the envelope, and I personally know 6 Medicaid directors in Texas since 2009. And that is a kind of a testament, I think, to how hard of a job it is. And quite frankly, when we look across the country, the median tenure for Medicaid directors is about 18 months or so. So, Stephanie, we're looking at you to kind of push the envelope on that longevity. No pressure, no pressure. So what I thought I would do is just sort of, like I said, kind of describe a couple of broad trends and themes that we see, and then I'll kick to Stephanie Stevens. And let me tell you, when we were doing the panel prep of like, hey, was Stephanie going to do it? Well, which one? Oh, okay. Stephanie Stevens is going to talk about what that means currently for the state of Texas, what's going on with the program now, what keeps her up at night. And then for some historical background and perspectives, and perhaps some perspectives from folks who have lived it, but aren't necessarily in the hot seat of the politics and the dynamics. Stephanie Muth and Billy will weigh in on a whole bunch of that other stuff, and then we'll do some Q&A at the end. So Medicaid, if you're a nerd, it's big. It is large and it is in charge. Medicaid is the largest health insurance program in the country. And even before the pandemic, Medicaid was covering 40% of all kids in the country, 50% of the births in this country. Medicaid is the largest payer of mental health and behavioral health services in this country, and Medicaid is the nation's long-term care program. That's a lot of things. That is a lot of things. It is a lot of things to a lot of people, and it's fascinating to see how broad the scope and breadth of the program has become for something that was designed really as kind of an afterthought to Medicare back in 1965. And because of the pandemic and because of laws that Congress passed and some of the economic dynamics going on, Medicaid now covers more than 80 million Americans total, which is 1 in 4 people in this country. So it has a sizable reach, and that is going to change sometime in the near future, and we'll get into some of that. But it is a significant program, and it is the underpinnings in a very, very real way of the U.S. healthcare system in a whole bunch of ways. And one of the things that we did at the association level over the past year is to try to say, what kind of pressures and what kind of dynamics is Medicaid under because of the pandemic, because of the economic situations surrounding it? And what we really looked at was 3 ways in which Medicaid has kind of always served as a significant underpinning, structural pillar of the U.S. healthcare system, and looked at ways in which the pandemic and everything over the past 18 months have kind of really undermined or laid under siege Medicaid's ability to do that. And those were behavioral health, children's health, and long-term services and supports. We've all clearly seen the dynamics of mental health services, of behavioral health services, addictions of all kinds, the need going up over the past 18 months. We have seen, the lifeline for kids. As kids have been, struggling to find stability in schools with the structure of what schools bring and school health and healthy school lunches and breakfasts. And then long-term services and supports, where, in institutions across the country is where we really saw an enormous amount of the mortality for the pandemic. So we tried to examine what those 3 pillars of the healthcare system have meant for Medicaid, and tried to think about, well, what do we do about them to strengthen Medicaid so that the next pandemic or the next whatever situation comes down in the future, we can think about how are we going to stabilize and support Medicaid to be stronger, to be able to withstand those. So we did a whole bunch of projects. They're called Medicaid Forward, and they kind of lay out roadmaps for states to think about, is there a small step we can take tomorrow that might have a little bit of good? And is there a large step that's going to take an enormous amount of work and a lot of partnering and a lot of bandwidth, but can have an enormous amount of good? How do you balance those, and how do you think about kind of moving us forward in all of that? I think the other thing that we saw throughout the course of the pandemic, and I know that it's been alluded to it a couple times in previous panels today already, is the staggering extent to which racial and ethnic disparities and inequities have been laid bare across the U.S. healthcare system. And that has been a dynamic that is very much true of Medicaid, but it is true writ much larger in the U.S. healthcare system, and quite frankly, writ large much more significantly throughout U.S. society as a whole. And, as we think about things, whether it's access or outcomes for anything ranging from maternal mortality to access to long-term services and supports, trying to think through what can be done to try to address those, whether that is that policy, what does that look like? This is a lot of things that are going on. This is a lot of things that are going on. And the other thing that I think is, and I'll stop and I'll turn to Stephanie. The other thing that has been really interesting about the trajectory of where Medicaid has been going for a number of years is the increasing reliance of Medicaid, of state governments, and the managed care industry. And right now, you look across the country, and you see that it is really the exception rather than the norm for a state not to have any managed care. And that there's a growth in utilization of MCOs or ACOs or other types of entities. There is a growth into the sort of more complicated parts of the system, individuals with disabilities, whether those be physical, intellectual, developmental, or within long-term services and supports. And it really sets up a really important dynamic between how the state government functions in terms of running and being responsible for Medicaid and the extent to which utilizing managed care to try to achieve those goals and how that gets done in a way that is meaningful, is responsible, and is something that provides improved healthcare access, improved healthcare outcomes, a better healthcare experience for the beneficiaries, as well as being as hewing and adhering to the responsibility of the state to be, a wise steward of the taxpayer dollars, and to make sure that something that is really what I like to call a real public-private partnership, but a partnership with accountability. How do we make that all work? How are we making it work pre-pandemic? How did we make it work during the pandemic? And what lessons are there for thinking about what does the future hold? So that's a bunch of stuff that's out there. Let me kind of move from the cloud down into the reality of what's going on in Austin and the rest of Texas. Stephanie, what is going on? What keeps you up at night? Do any of those themes resonate, or are there things that I completely missed?
Thanks, Matt, and thanks THP for having me here today. It's very special to be on this panel with Stephanie and Billy, who I worked with previously in their roles as Medicaid director, and I definitely would not be in my role here today without them. So I guess that means the things that keep me up at night, I can call you at any time when I'm awake in the middle of the night. And Matt, certainly things you said resonate, but you also asked, is Texas unique? And so, of course, Texas is unique. And we are like to think of ourselves as different than other states in certain ways. And so some of the focus areas are really specific to Texas in some ways. I mean, one of the things that we're very focused on at the agency is our 1115 waiver. As you may know, we operate Medicaid managed care and various programs under an 1115 waiver. And we received a 10-year extension back in January, which the federal government subsequently rescinded. We are currently operating under that January waiver and are working to make sure that we have a system in place that provides long-term stability, but still are awaiting some pretty critical CMS approvals. And I'll kind of talk about what path we're on. So we had put forward to CMS potentially a short-term path where we maintain certain existing programs that provide funding to hospitals and nursing facilities, and also continue to fund delivery system reform in Texas. But at the same time, we want to work with CMS on our long-term path to make sure, again, that we have that long-term stability and provide some level of certainty moving forward. for the managed care organizations and our providers and all of our stakeholders. We meet with CMS literally every 48 hours at this point, so we are talking to them frequently and really trying to move towards approval both in the short term and the long term. That, of course, all happens within the context of the ongoing public health emergency, and I started my role in May of last year. Stephanie left in May, and I started right when we already had some good structures in place for the public health emergency, but I have definitely been in my role under the public health emergency. And we did things with many of you that the state has not done in the past, and there was a lot of effort into providing flexibilities for providers, for the managed care organizations. But one of the things I think all states are very focused on, including Texas right now, is eligibility, which I think you mentioned. So we've seen over a 30% increase in the Medicaid caseload since the start of the public health emergency. We're at, I think, over 5 million now in Medicaid. And it was really unprecedented to change the Medicaid rules to keep folks in the Medicaid program. And it's going to be a significant effort that we will need to collaborate with many of our stakeholders to unwind that. And so there's still uncertainty around what that looks like, and some of it depends on federal actions that may occur. But we are actively planning for the end of the public health emergency and returning to normal eligibility rules. And of course, I think one thing that we want our stakeholders' help with is really messaging to members to make sure their information is current, because when we do this massive outreach, I think there's a real anxiety that people's information is not going to be current. People are going to have made changes during the public health emergency. So we need you all to help us make sure we have the best information on members so that we can, reduce churn to the maximum extent possible. And then I'll just mention one other thing, which I can't say much about, and I'm not too sad about that. But of course, we have a number of major procurements that also keep me up at night. We are in the process of re-procuring all of our managed care products, as well as significant IT procurements. And those are always a focus area for the Medicaid program.
All right, excellent, thank you. So there's a bunch of things in there that I want to unravel or unwind and get into more. Stephanie Muth, since Stephanie Stevens talked about kind of the transition in the midst of the pandemic and the waiver approval, which was kind of unprecedented for a state to get a 10-year waiver approval. And there were a
Texas,
couple.
Matt.
You are Texas, you're great. Although I think Tennessee got one too, and I think Florida got one too, so, they all got theirs rescinded as well. Stephanie, what was your kind of experience? Like how did you see kind of the evolution of that waiver and all of the work that Texas has been doing under your couple of years at the program, kind of, leading up until now? Because obviously there's also a pretty significant change in administration in the midst of that pandemic. But like, how did you see kind of like the evolution there over the past couple of years?
So I think that, obviously the pandemic changed everything, and the state, there was a lot of work that had been done through DSRIP, trying different programs, working on things like social determinants of health, and a lot of lessons learned through that fed into the proposal that the state put forward after my departure. But I think that Texas has always had an approach that CMS has not always been comfortable with the approach that Texas has, and with all of the things that came up in the year prior to my departure, the new financing rules and other things that would really have impacted the MFAR rules that really would have impacted Texas. So it's just constantly trying to navigate what's best for the state and what can you do with CMS? And that is it is a constantly evolving and changing landscape, I would say.
Yeah, and I think that's a great point, and I think that would that would be something I would reinforce for the audience as folks who work and live and work in the Texas healthcare space, in the Texas Medicaid space, where your primary engagement level is with the state government folks. You can never forget about the federal perspective, and the feds pay for at least, and sometimes significantly more than 50% of the Medicaid program in every state. And because of the way that Medicaid is structured, in that it is an entitlement, it's an entitlement to the beneficiaries, it is also an entitlement to states. So as long as states spend money on the Medicaid program appropriately, the federal government has to keep spending its share. So there is always this dynamic of, to your point, Stephanie, are we comfortable with the way that you're spending this money?
That's right.
And that is true of all administrations at the federal level. It's their perspective. They think it's their money. They want to make sure that we're all spending it correctly. So Billy, a lot of the stuff in the waiver and a lot of these dynamics, I don't know if you consider yourself the father of some of these, but how do you see sort of things have changed over the past decade or so?
Is Stephanie blaming me for the waiver? I just need to know that. So the waiver is kind of funny because if you look at it originally, what the original purpose was compared to what we're doing now, it was kind of a simple concept. It was this. We want to expand Medicaid managed care, capitated managed care statewide. We want to implement dental managed care. We want to carve in pharmacy to managed care. And oh, by the way, we wanted to carve inpatient services into Star Plus. Now, who carves hospital services out of managed care? Texas was. Why? Upper payment limit. Upper payment limit, I know you guys don't want to get in a big Medicaid finance debate right now or discussion, but basically there's a program in the federal government that allows hospitals to be paid the difference between what Medicaid paid and what Medicare would have paid using a non-state government organization dollar. So that comes in the state, we match it, but CMS says it's incompatible with managed care. So for many years, we kept inpatient services out of managed care. That always bothered us, as you would imagine, because you can't really manage care when you take that big component out. So that was really the impetus around the waiver. We went to CMS and talked to them about what we could do. We had discussions with the hospital industry, and we got some legislation passed with Jamie Dutensingh's help that really forced us to pursue that path, to obtain a waiver that would allow us to carve inpatient services back into Star Plus. We also netted a huge increase in the amount of dollars that were available. Mm-hmm. At that point, we had about $3 billion a year in managed care UPL payments. So we were able to convince the federal government that that should really be about $6 billion a year because of there's funny math you work when you're talking to CMS. It's called the budget neutrality analysis. So we were able to get those extra funds, but remember this is 2012. And we were talking to CMS. You had the ACA just passed. You had Medicaid expansion was a foregone conclusion. And we told CMS, look, Texas doesn't have the infrastructure to support this. We have 5 or 6 million uninsured. We have about $8 billion in uncompensated care. So they were agreeable to it, and we could establish these uncompensated care funds and DSRIP to invest in infrastructure. And so that was the environment. And now that's kind of changed because once the Supreme Court ruled and we went back to CMS and said, no, we're not going to really expand Medicaid. They weren't too happy with that. Really encouraged us to, given the huge waiver that we had just obtained. But, that's a public policy decision the legislature made not to. And that's kind of where we were with the waiver then. And of course, it's evolved over time with a bunch of different payment components.
Great, thank you. So let's then, because I think you're teeing this up a little bit, let's address one of the, I don't know if it's an elephant in the room, but it's just outside the room. But there are significant congressional packages building back better and infrastructure and all this stuff that are currently being debated. I'm not going to sit here and pretend like I'm going to predict exactly what's going to happen or when or who's voting for what or if it's going to change, but there is an enormous amount of energy being put forward into putting a number of Medicaid policies into those proposals that could have significant repercussions for states across the country, and perhaps even more significant repercussions for states like Texas and others who have not, embraced the Medicaid expansion for whatever reason up until now. And I think Billy, you teed up something which is, since the Supreme Court came along, almost a decade ago now, and essentially declared the Medicaid expansion that was envisioned as part of the Affordable Care Act to be unconstitutional, left it in the hands of the states to make that decision for themselves, which at this point, I think all but about 38 of the 50 have done so. And there is, one of the questions, one of the debates in policy circles in and around the Beltway, where I live and work, is, what is it going to take to get the rest of the states there? How do we address the coverage gap? Because if you understand how it all works, there's this interesting dynamic where in states that have not expanded, there's a cohort of people who are too rich to qualify for Medicaid, not wealthy and not wealthy enough to qualify for subsidies on the exchange. So there is a coverage gap. And one of the dynamics over the past number of years has been, well, what might it take to get states to come and kind of do something about that? Well, I think, based on my conversations with policymakers in DC, in the administration, in the House, in the Senate, quite frankly, they're tired of having a conversation around how do we entice the states to do it. And they've come to a point of saying, we don't think they ever will, so we're going to try to make it very, very difficult for them to say no. So some of the policies that are in that provision are no longer in the, here are some carrots to get states to do it, but rather, here are some sticks that we're going to hit you with if you don't, such as dish cuts, getting rid of supplemental pools, or at least reducing them, and other types of things. So I'm not going to put Stephanie on the spot for any of this, because interestingly, the other Stephanie, I came out and testified before the Texas legislature a couple years ago. You were, I guess, in your last year, talking about how is Texas, is what Texas is doing, similar to what's going on in the rest of the country? And I said, but pretty much yes. And there's a lot, there's a lot of things going on that absolutely doing that. But then they started saying, well, what do you think that Texas should do about the expansion? And I was just like, that's just not my job to answer that question. It's not her job to answer that question either.
My job
this is above our pay grade. But they wanted to make a point. Anyway, so understanding it is above your pay grade, above my pay grade. I don't know, Billy, Stephanie, how do you see this if this gets passed? And it is not in law yet. How would you see that dynamic playing out in Texas with hospitals and other entities getting really under the gun financially?
Well, go ahead.
Well, I was just going to say, Texas may not have responded to carrots, but I really don't think Texas will respond well to the sticks either. Okay. And I'm not sure, Billy, what your thoughts are. I mean, it will be interesting to see how this legislation plays out and whether it's going to have the support. And there's a number of things that is in the Build Better Back legislation that seem to really impact the Texas Medicaid program, including requirements for 12 months of continuous eligibility for kids, and the pregnant women coverage, and how you can unwind from the PHE. So, one of the interests in Texas, which may be different than other states, is that when we took the deal for extra FMAP, the thought was that that was going to be a good deal for states, but nobody realized that this PHE was going to last as long as it has. And come about February, the state starts losing money on that. So that legislation also restricts what you can do to disenroll and the length of time. At the same time, it's also cutting back on that enhanced FMAP. So I think, certainly there's a lot of things that won't work well for Texas in that, but I really don't think having some of those sticks is going to change the position of state leadership around the question of expansion.
Okay. Billy?
So every study that's been done in Texas, around Texas, by a liberal think tank or conservative think tank has said Texas should expand Medicaid. It's cost effective, it creates jobs, it's good for the economy, it solves many problems. Now, it doesn't solve all of our uninsured. We've got a lot of uninsured. It's about 1 million people. You'd still have 5 or 6 million people uninsured. But I think it would be reasonable that if the federal government came in and said, this demonstration waiver you have is really to demonstrate a concept. And I don't think paying for uncompensated care for a population that could be covered by health insurance demonstrates a concept. In fact, as a taxpayer, I'm a bit offended by that, because you could provide health care coverage, not just paying uncompensated care for this population. So that would be a stick, and I don't think that we would react well to it. But I think it's a reasonable stick. If you have a carrot that says, if you do this, you can get 90% match, you can do all these things, and you still haven't done it, and you have all this evidence that suggests that it's the right thing to do, then what else are you going to do? You're going to keep reinforcing bad public policy or bad behavior? Consequences.
Consequences. Got it. Thank you. All right, so I'm going to do a soft pivot and kind of go back to a point I was making earlier around the increasingly intertwined nature of healthcare delivery in states in Medicaid with managed care plans, and that it is, it's funny when I talk to state legislators a lot, I get this interesting kind of political dynamic where, if a state is just getting ready to go into a big managed care procurement or something like that, I'll get kind of the Democratic lawmaker saying, well, you're privatizing, and that's bad, because who's in charge? And then you'll get more conservative lawmakers saying, you're privatizing. That's great. We can get rid of state government. We don't need them anymore. And I have to kind of explain to both of them that, well, no, neither of those is true. In fact, the buck stops at the state, and if healthcare is not delivered, on time, on budget, if the outcomes are bad, if the access is bad, if the quality is bad, it is absolutely the state government that is responsible and cares very, very deeply about this, and has to ensure that, moving forward, the plans are used as a tool in order to achieve those goals. And then, quite frankly, that often involves making more investments in state government, because you just need different skill sets to be able to do this stuff. You don't need a bunch of claims processors. But within that theme of the increasingly intertwined, if you win, we win, if you lose, we lose dynamic, the next couple questions I want you guys to answer kind of through the lens of what does Texas need from the health plans in order to achieve this? So one of the things, and I think, Stephanie Muth, you hit on this, was around social determinants of health. And I think it's the good news on this is that the debate around what are they important to pay attention to? Should someone be investing in housing, nutrition, preventing trauma? That debate's over. The answer is yes. But the questions that it leaves are, well, who should pay for it? How much should we pay for it? What are we paying for? And what is that dynamic? And I know that a lot of states are increasingly looking to the plans to kind of leverage their ability to think creatively around this. What more needs to be done? I'll start with you, Stephanie.
So I think, and I just want to touch on something you said before, because part of the focus of Stephanie's tenure was on this managed care partnership, and particularly there was a theme of oversight and what was the state's role. And I think through those discussions, we talked a lot about the role of the state and the different mechanisms we have in place to oversee the managed care organizations. I hope we're moving to a slightly different discussion and focusing more on the services that we deliver and the way in which we deliver the services. And we talked about the framework of the waiver, and I think we will continue to use it in Texas to move additional groups and services into managed care. I mean, we're a managed care state, but there are still things that are outside of the managed care model. So we recently moved medical transportation services into managed care. One of the things that we're doing over the long term is looking at long-term services and supports for people with intellectual and developmental disabilities and other similar needs, and looking at how managed care can serve those individuals. So we will continue, I think, to evolve the managed care model itself in Texas, and we'll work with the plans to be good partners to make sure that we're delivering the services that people need, and the specific services that people need, which is different depending on who we're serving. The other thing that I think sometimes the managed care organizations realize, but maybe not everyone realizes, that, Medicaid is constantly evolving. So, you mentioned some of the things, or Stephanie did, that are in the federal bill around services for women. And Texas has really been evolving the services that are available to women through Medicaid over the last year, and passed in the last legislative session 6 months of postpartum coverage. So within the managed care model, the state is continuing to improve the continuum of services that are available. And getting more into the, what's in the future, and we are closely working with the managed care organizations on how we promote value through managed care. So we maximize the managed care model for a number of reasons in Texas, and we want to continue to flow that down through the healthcare system. And so we have a strong foundation of programs that are meant to promote value, and we are going to continue to evolve those and really advance the definition of value in Medicaid managed care. And I know you've done a lot of work with social determinants of health. I don't know if you want to speak specifically to that.
Yeah, I do think, though, that for Texas, one of the big questions around social determinants of health, I think you're right that there's a general acceptance that there's the relationship to healthcare and healthcare outcomes, and that needs to be addressed. I think the question that's still outstanding is, what is the Medicaid program's role in addressing that? And there's not clear consensus from the state leadership in that area. And I think that's really an opportunity for the managed care organizations, and you're seeing a lot of that. And really that is the strength of managed care. It's the ability to do things that the state doesn't have that ability to do, the flexibility to recognize that these factors are impacting health outcomes for the individuals that we're serving. So we need to address those. And you're seeing a lot of pockets of that across many of the managed care organizations in Texas. And I really think that's where it has to start before there is, in my opinion, an institutional acceptance of Medicaid has a role in doing this, and the state defining whatever that is. We've got to prove this concept through the flexibility that's afforded to us in the managed care environment.
And Billy, were social determinants even a thing in 2012?
No, that was kind of a party, wasn't it, or something? Stephanie has a good point. Social determinants, the value to me of managed care has evolved. originally and I've been around long enough where I remember fee-for-service and PCCM and all those things that don't exist any longer. But the value managed care then was budget certainty. Everybody would come in and go, you can predict what your budget's going to be. And it's evolved now into the value proposition is innovation. And it gets to be what I think Stephanie Muth made a well-made point around social determinants. Yes, it's an issue. We know that. We know when you start looking at superutilizers, what's driving a lot of that utilization is social determinants. You can start looking at adverse childhood events and what's going on with that. Well, social determinants. So it helps to have, in Texas, we have 20 managed care plans, 19, 20?
19.
We have 19 partners, public policy partners, that can help us educate members of the legislature. What you're seeing is that if you invest money in SDOH, we're going to get a return. In Texas, I see SDOH as a cost containment approach where you can better contain and control the growth in your cost. So it helps to have partners that can engage with that public policy education process rather than the state agency trying to take that on by themselves.
Yeah, and I think the the dynamic there is, should Medicaid, whether that be Medicaid as the state, Medicaid as the health plans, should Medicaid be involved in some of these social determinants where it clearly and obviously can have a huge impact on costs and quality at the same time? So, for example, in Arizona, they got this great program where they're, one of the health plans, or maybe it's several of them, are using reserve funding. So there's an agreement with the Department of Insurance to essentially buy housing, supportive housing. And they're focusing it on a relatively small subset of homeless individuals with substance abuse and co-occurring mental health conditions who otherwise are spending 100 days in the ER and they cost $1 million a year or whatever. And if they find you just give them supportive housing, their costs drop significantly and it's a huge cost savings. So that's like a real no-brainer. We should all do that. But where does that stop? There's a continuum of, Medicaid's not going to be providing supportive housing for 80 million people. So at what point do you stop? And at what point do you find that line of, well, this is no longer saving money. It might be a social good. It might be the right thing to do. It might improve outcomes, but it clearly doesn't save money. So that's, I think, the thing that we're going to continue to grapple with. And I think what states need from our health plan partners is a good dance partner in trying to figure that out. Because, again, as you've said, the debate in Texas is true in so many other states of something should be done. Should we do it? The analogy I like to use is it's kind of like stone soup, in that Medicaid can come in and put the stone in the cauldron, but we're going to need other people coming out and putting in the cabbage and the carrots and the meat and whatever in order to make this sustainable. So we're going to need your work on that. And again, I think the theme that I try to draw is that partnership, because when you succeed, we succeed, and hopefully vice versa.
And Matt, can I add something?
Absolutely.
I think the thing I would add is, Medicaid in Texas sits within a larger health and human services system. And so I think one of the questions for the agency that I'm at is, what is the role of Medicaid and what is the role for other parts of this organization that we have? Because we are doing the eligibility, we have the front door, we are providing services that aren't Medicaid as well, and we have Medicaid, which is often the biggest. But so we have to think about, how does Medicaid fit into this larger health and human service system as well, and what is the managed care organization's role within that system, so that we're not creating a lot of duplication across the organization.
Exactly. We have a lot of things to figure out at the state level with all of our silos. That there's all the feds and all of their various programs that they can bring to bear that haven't been coordinated very well in the past. There's charities and CBOs that need to be blended and braided into this, and it gets real complicated because there's limits on what states can do and there's limits on what plans can do. Because the dynamic for you guys is, the more you start putting into non-traditional services, well, guess which part of the medical loss ratio that ends up in, and that's not a real formula for long-term success. So, we're going to have to continue to work on that. So couple other things kind of relating to this. I know each of you kind of hit on this a little bit with the unwinding of the public health emergency. So I just want to put kind of stress the dynamic that's coming on that. So, like I said at the outset, Medicaid is now more than 80 million people. It's 5 million plus now in Texas. And part of that is that, because of federal law, pretty much not a single person has been disenrolled from the Medicaid program since the beginning of the pandemic public health emergency. And that's going to continue until, the public health emergency ends, which will be, I don't know, January, May, June of next year. We don't know. And it's going to create an enormously difficult challenge because you will have now, 5 million people here in Texas, and you're going to have to figure out, what are we just going to do eligibility determinations for 5 million people, on day one, or are you going to try to stretch that out, at least for to make sure that the eligibility workers and the eligibility systems aren't completely overloaded. But of course, state legislators and other policymakers are going to say, wait a minute, these folks have been on the rolls for 2 years at this point. Let's get this thing moving. And part of the other dynamic that I think it's important for people to recognize is that, states have got they need a long leadway, a long runway to figure out how to actually do this, whether it's the figuring out what kind of systems do I have to build, what kind of bandwidth do I need at the eligibility worker level, what's my appeals process capacity, and states were moving in a certain direction and working under the auspices of guidance that came out back in about a year ago in November of last year under the Trump administration, and working towards a solution. Now there was a political change in Washington, and the Biden administration came out with a new set of guidance. And states, and that was a couple months ago, states had to kind of pivot their plans and rethink where they were going and say, okay, well, we got a new thing we're shooting towards. And could get completely changed if the Build Back Better passes, because there is yet a third completely different way that states and Medicaid is going to be expected to think about this. How are we going to do this? And I think at least one of you sort of said in reference to the plans of how are we going to communicate what's going on here to the people who are otherwise going to lose coverage if they don't respond? Did they move? We don't know. How do we do this with the uncertainty or without it? And how can the plans be good partners? Stephanie.
Can I add one thing to that?
Yes, you can.
I think that it's very important to also think about states were given a week to implement this. Anybody who has this is a massive rules-based eligibility system with all these complex rules, and suddenly we had to tell it, don't disenroll anyone, and if you do, you're risking losing FMAP. So basically across the country, states had to break their eligibility system, and and now we have to unbreak it. But it created a lot of confusion for members. So the member confusion is rampant in terms of sometimes they got a notice, even though, because you cannot turn on a dime like that with such a complex system. So unwinding that, and I think Ms. Stevens mentioned this, the biggest challenge is going to be around that member communication. And I know the agency has been engaging the health plans on this, and health plans have a vested interest in making sure their members understand what's happening and what they need to do. And I think that's really going to be one of the biggest challenges, but workforce is another. Just like everyone is struggling with workforce issues, the eligibility staff, it's been a challenge to retain them in this economic situation. So we've got some significant resource constraints and expectations that we're processing those. I still say we, sorry. The state, we as the global state, but that we're processing those quickly. So it's really going to come down to communication to members.
Yeah, and I think at this point, the message is don't wait. There's uncertainty about how this is actually going to look and unwind and what the timelines will be, but members can do things today to make sure that we have accurate information for them. We are continuing to do renewals. We obviously don't make anyone ineligible who we can't, but for those folks, they're getting new coverage periods. So I think members can be doing things to communicate with the agency to hopefully make it smoother, but there's uncertainty.
Yes, there is. Anything that, Billy?
No, well, I agree. I think that, the health plans do a lot of things very well, and I think one of them is member engagement, and probably more so in the past over the COVID period where they've looked at different ways to do that. So any way they can help the agency with getting the word out, particularly updating your contact information and doing those things will help ease the burden.
Okay. So we've got a little less than 10 minutes left, and I do want to make sure that we carve out a little bit of time for questions from the audience. But I want to leave you guys with sort of it's not a lightning round, but it's a kind of a last reflective question of kind of kicking all the stuff back upstairs and sort of saying, as Medicaid has, it is now a much different program than it was 10 years ago, 20 years ago, and likely different 5 years from now. What does state government need from the plans to be good dance partners in running a highly effective, efficient, high-quality Medicaid program? Stephanie, can I throw?
We should start with Billy.
Start with Billy? Sure.
The graybeard.
Yeah.
Well, I guess I go back to innovation because you guys are at the cutting edge of things. You know what's working and what doesn't work. You're very much in tune with the population. And as a state moves more and more members into managed care, they don't have as much contact with them like in the old fee-for-service or PCCM days. So innovation, great ideas, cost containment, improvements in quality, innovation, in a word.
Okay.
I think the partnership Jamie used to always say that, which I stole from her, which is it's not just partnership, it's a partnership with accountability. And the state is asked to do more and more with no more resources. We used to manage one contract with our claims payment vendor, and now we have a very complex system that there's great benefit from, but in terms of administering that system, the complexity has increased, and it's a challenge for states. I'm going to say something that may be a little unpopular too, but I think when we talk about partnerships, the other piece that the agency is facing is the managed care procurement piece. And we've seen a big shift in the national landscape around managed care procurements. When Billy was Medicaid director, there wasn't a lot of noise around those procurements. Stakes have increased. I understand that. But you look around the country and almost no state has been able to execute a managed care procurement. And in the long term, for the health of the Medicaid program, I don't know what the solution is, but that's not a good thing when we cannot do a successful procurement for Medicaid managed care organizations. So again, I don't know what the solution is, but I do think that should be a concern.
Okay.
And of course, I agree with their brilliant thoughts. I think, we've touched on it today. Medicaid is not the same as commercial insurance, so we have a lot of expectations that may be very specific to the Medicaid program. And so I think we look to the plans to work with us on sort of implementing Medicaid in that context and being flexible. We ask for things to be done differently than they may be done in different other contexts. And so just sticking with us and being flexible as we work through those things.
All right, sounds good. We've got time for a little Q&A. The Klieg lights are right in my eyes. I have trouble seeing if there's actually hands raised or where we are. So
Any questions?
Don't be shy, people.
I have one last question, if no one else has one. You've talked a little about the Build Better Back Back Better Act.
Whatever
It's a
it is.
tongue
The
twister.
BBB.
The BBB.
You've kind of talked about some of the sticks in it. What are some of the positive things? I know that we're still waiting to see what's going to happen with it, but there are some pretty interesting pieces in there.
I think, I mean, there are pieces in there that will, at least in the short term, address some of the coverage gap. There's tax credits for some of the folks in that coverage gap to buy coverage on the exchange. You know, that's something. I think there is, it doesn't really help Texas, but there is the bill addresses a long-standing huge inequity in the Medicaid program for the U.S. territories. Puerto Rico, the Virgin Islands, American Samoa, the Northern Mariana Islands, and Guam have been chronically, and I would argue criminally underfunded at the federal level. And we talk a lot about inequities, but there's a lot of disparities and inequities in the territories. They get permanent reauthorization of more money and some expectations of, you know, raising their game as well. Critically overdue. It permanently reauthorizes the CHIP program.
Yes.
Thank God. I don't know why that took, 20 years. It's the most popular, it's the only bipartisanly popular healthcare program that we've ever done. And it's always been just kind of like, oh, we're going to authorize it for the next 3 years. And I remember the last time they reauthorized it, they screwed up. Well, they didn't get to it in time. They're like, oh no, we're going to get it. And states had to send out disenrollment notices to people saying, we're going to cut you off. And that is just so destabilizing. It didn't happen because Congress came in and did it last minute, but they never appreciate just what that means in the real world. And that's really destabilizing. So that's a good thing.
And I would add, I mean, depending on the perspective too, but so in Texas, we do periodic income checks for the second 6 months of Medicaid eligibility for kids. So there's a provision in there that requires 12 months continuous. So it would do away with that. We also do a 6-month check on CHIP, and it requires 12 months continuous with CHIP. So the way that I read the bill, those things would be eliminated, which would provide more continuity of coverage. But those are hotly debated political issues in Texas. But depending on your view, that could also be seen as a positive.
Gotcha. Okay. There's a lot going on there. All right. Lori, any other last questions?
No, I think we're at time.
We're at time.
We would
all
like
right.
to
Well,
thank you.
I want you all to join me in thanking all three of these folks. This was fantastic.